So in this talk, we're actually going to talk about what causes inflammatory bowel disease. And by understanding the pathophysiology, we may provide some clues as to why there's an increasing prevalence in the world. And this is very prescient when it comes to all health, because as we all know, the gut is the center of the universe, right? It's more important than the heart or the other organs, right? Just kidding. We're going to talk about IBD and its phenotype. It's not as simple as say Crohn's and ulcerative colitis. It's actually a complex spectrum of inflammatory disorders of the bowel. And so it's not easy to just say Crohn's or UC. And then we're going to talk about the exciting world of the emerging therapeutics in the IBD space. It's never been more exciting to be an IBD physician right now. And then we're going to talk about a couple of solutions that might be helpful to you all in terms of preemptively or proactively preventing lapses in drug infusion, working with your clinician, authorizations, et cetera. So we'll get right into it. So inflammatory bowel disease is a chronic, relapsing, remitting, inflammatory gut condition. So it comes and it goes, and over time it causes quite significant damage to the bowel. Turns out that there's also about 10 to 15% overlap where people have features of both, and we call that indeterminate colitis. And that's often treated more like a Crohn's disease. We'll talk about why there might be patients who have features of both in just a bit. Let's talk a little bit about its prevalence. Now, this should be a little bit alarming, but hopefully not surprising to this audience. You all take care of many chronic inflammatory conditions. IBD, through the last several decades, has been gauged in terms of prevalence, and every decade we see an increasing incidence and prevalence throughout the world. This is for Crohn's, and it's also true for ulcerative colitis. And what you will observe if you look at the heat map is that you see IBD increasing in prevalence in countries of privilege, okay? So countries that are westernized, higher socioeconomic classes, we see increasing prevalence there, whereas it used to be less common in the developing world. But even in those developing nations, take for instance my country, South Asia, we see an increasing incidence of inflammatory bowel disease. So what do we know about the causes of IBD? So to date, there are 270 genes that have been identified to be associated with the development of Crohn's and ulcerative colitis. Not a single one is actually known to cause it. If you take a panel of genes, not a single one or single panel has been shown to cause it. If you've been diagnosed with IBD clinically, and then you do a genetic panel, it may inform you about how aggressive the disease may be. There's some genetic markers that predict whether you'll need surgery, whether you'll have disease in the ileum, the end of the small intestine. But otherwise, genetics don't seem to be the only picture. If you go to a twin conference, and this exists, anybody have a twin here? No? Okay. If you go to a twin conference and you set up a booth, and you say, calling all twins with Crohn's and ulcerative colitis. One twin has Crohn's, one has ulcerative colitis. They have the exact same DNA. But then you actually look to see how much of the DNA contributes to the development of that phenotype of IBD. For Crohn's, it's about 5 to 20%. For UC, about 5 to 30%. That means that the balance is this unknown, this environmental trigger. So if you look here, all sorts of things have been associated, some controversially, some not consistently from study to study. Appendectomy may be predictive of Crohn's, may be protective in ulcerative colitis. Tobacco makes Crohn's worse. Tobacco makes nothing better. Dysbiotic microbiomes, where your gut microbiome is off balance, have been associated with the development of IBD, but so have dietary emulsifiers. These are the foods and preservatives in our food that make them last longer. Think of a Twinkie that should have degraded 5 weeks ago but has been on the shelf for 10 years undegraded. Those dietary emulsifiers have a dysbiotic effect on the microbiome where it disrupts the microbiome and has been associated with the development of IBD. So have food coloring dyes. Yellow number 5, if you have a mutation in your interleukin-23 cytokine, has been associated with the development of colitis. When was the last time you looked to see if you were ingesting yellow number 5? I'm not suggesting you completely avoid it. There's still more studies to be done, but there's good science that's developing. If we start therapy too late in time, we have less ability to heal, make a difference, prevent surgery. We might have to do less surgery, remove less of your bowel. But wouldn't it be great to start therapy early at a time point where we can prevent that tissue damage? And that's where our treatment paradigm has actually flipped. And now we come to the magic era of biologics and small molecules. Back then, for the last 15 to 20 years, we would reserve those for more severe disease if they fail these treatments. And then surgery. Now, I'm going to put it hopefully in the language that many of us speak when we deal with insurance authorizations, which is patient must fail conservative therapies. And you'll recognize that many of those conservative therapies listed on that form are in the bottom part of the pyramid. I've also reviewed that if you have disease that is unchecked and you start treatment too late, the patient will need surgery. I've also reviewed that many of these therapies in the bottom part of the pyramid are ineffective for the induction of remission. Essentially, we are doing a disservice to our patients. And we've known this. Up until 1998, we didn't have anything in our armamentarium for IBD beyond steroids and surgery. Now we have a plethora of treatment options. We have flipped this pyramid, and we have been able to show over the last 15 years with data that when you start biologics earlier, you can start to make a dent. You can actually start to change the evolution of the disease. You can actually prevent surgical interventions, reduce the amount of surgery, reduce the amount of tissue damage by starting early. So now the mantra is bottom down. Even if the disease is moderate or severe, we don't have to jump to surgery. We can institute medical therapies that I'm going to go into, and they can be very effective when used appropriately. They can be very effective when the scheduled infusion or ingestion schedule is not interrupted. So let's talk about the treatment options that we have. There are several different categories and classes, and I'm going to go ahead and itemize or explain how they work mechanistically. In the bottom box here, we have medical treatment options that are conservative that I talked about, steroids, mesalamines, immunomodulators. But on the right, we have monoclonal antibody therapy. We have monoclonals that are antibodies that block certain cytokines that are pro-inflammatory, meaning white blood cells cause the inflammation. And then we have some antibodies that prevent the white blood cells from trafficking to the gut. So let me give you an analogy here. If all of us are white blood cells circulating around the body, okay, we're in the artery, that's what we do, we like to circulate. We like to go to our lymph nodes that are all throughout the body and kind of hang out there, kind of mature, okay? Those are our germinal lymphoid centers. We're white blood cells. All of a sudden, we hear a call to the gut, and we have to get to the gut because we think there's an infection. So we all mobilize, and we Uber pool it down to the gut, okay? We go down the highway. We don't get off at the heart, the kidney, the lung. We go right to the gut and cause inflammation. That is Crohn's and ulcerative colitis. Now, how will we commute to get together? Well, we communicate through inflammatory hormones called cytokines, TNF, IL-2, 6, 10, 12, 13, 23. These should maybe sound familiar from some of the mechanism of the drugs. Those cytokines create inflammation, and they allow us to signal to each other to coordinate a group attack and go down to the gut. So anti-TNFs block TNF. Simple. Anti-IL-12, 23 agents, it's an antibody that knocks out two cytokines, block two cytokines. Now, two cytokines are not better than one. Anti-integrins, which is vedolizumab, I'll illustrate these, that medicine does not block a hormone. If we can still all communicate through the same hormones and get on the artery highway to the gut. But what Entyvio or vedolizumab does, it prevents us from getting off at that exit. So those white blood cells, they can go to the heart, they can go survey the brain, prevent infection there, right? White blood cells are always, right now as we sit here, are preventing our body from succumbing to infections. So vedolizumab prevents the white blood cell from getting off at the gut and causing inflammation there. So this is a mechanistic diagram or illustrating the different hormonal pathways. I've basically just tried to zone in on TNF and IL-12 and 23 as the mechanisms by which our mainstay of therapies now target. So the great discovery or advent to the market was infliximab, and now there are many biosimilars that have come to market of infliximab, followed by adalimumab, 6 biosimilars awaiting market to come out in July of 2023. And then we've had basically from 99 to 2013, it's like 14 years, right, after clinical trials, we basically had the same agent class, right, anti-TNFs, some for Crohn, some for UC, based on the label and the clinical trial that was done. That was 14 years of the same therapy. Now, make no mind, this is the gold standard of biologic therapy in our field right now. It was in 2014 that we had vedolizumab, that's the anti-integrin that's gut-specific, and then ustekinumab came out later. It was already well established in the rheumatologic world for 9 years, I believe, prior to that. And now we have the small molecules. So all of a sudden, what you've seen in my world is this dramatic increase in drug therapy. You can correct me on the numbers, but this is exciting to me because in the dermatology world, I think there's like 14 to 16 agents. In rheumatology, something like 24 agents. In my world, we just have 5 mechanisms of action. But there are 58 molecules that are being currently developed in the IBD space. That's just drug therapy. There's also stem cell therapy for perianal fistulizing disease. 1/3 will lose response after the first year of therapy. It's a very short-lived duration of time, and the reason they do is because we develop antibodies to the drug. I'll tell you why. Infliximab was known as a chimeric protein. It was part mouse and part human protein. I'm pretty sure you guys all know you're not mice, right? And your immune system knows that too. So the immune system would form antibodies against that protein. So antibodies to neutralize the antibody, drug-neutralizing antibodies. And so if you bind the drug, the infliximab, lower level, and you lose response. Adalimumab, you all know the commercial name is Humira. It got its name because it's fully humanized. It's a fully human protein. But your body's so smart that it still knows that your body did not produce that human protein. And so you can still develop antibodies to that. And we believe you can develop antibodies to certolizumab and golimumab as well. The more mainstay modern-day therapies have less immunogenicity. So ustekinumab, patients only have antibodies 2.77% of the time. I've only met one patient 1 month ago, approximately, who's ever developed an antibody to ustekinumab since it's been out, and I use a lot of it. And having that antibody, we don't even know what its significant means. So with anti-TNFs, you commonly see us weight-based dosing infliximab higher and higher, 5 to 10, sometimes more, increasing the interval from every 8 weeks to every 6 to every 4. You'll see that with adalimumab, reinduction dosing with certolizumab as well. But with ustekinumab, you see us doing that less often. We do a lot of more IV reinductions. And I'm trying to think of the salient points that might be helpful for this audience. We believe that drug levels guide our treatment options. And with ustekinumab, you'll see more of our gastroenterologists using ustekinumab levels, a trough level drawn within 24 hours prior to their dose. And if a level of 4.5 or higher, it's deemed pretty good, okay? Doesn't seem to make a difference if you're 5 or 10 or 50, okay? Same thing with vedolizumab. But 4.5 is the magic number. If it's less than 4.5 and they're having a partial response, we will go ahead and reinduce, meaning give them another IV dose or appeal insurance to increase the maintenance frequency of their sub-Q injection every 6 or every 4 weeks. So IL-12, 23, that's what ustekinumab blocks. It can also reactivate TB and Hep B. Anti-integrin therapy, vedolizumab, doesn't do that. It doesn't reactivate TB. It doesn't reactivate hepatitis B. In fact, it's an extremely safe medicine. And all of these are really safe, to be honest. If you look at my hands, I always tell patients this. Prednisone suppresses the entire immune system throughout the body. Anti-TNFs and ustekinumab, they suppress a portion of the immune system, just a portion, throughout the body. Vedolizumab suppresses a portion of the immune system just at the gut. And sometimes getting them through that is the easiest way for them to understand how immunosuppressed am I really, right? And it turns out it's very focal. This is all smart therapy. Vedolizumab is an excellent medicine. Remember, it's the medicine that prevents the white blood cells from getting off at the gut, but it permits those white blood cells from circulating throughout the body to go ahead and prevent infection in other parts. So it's a very useful medicine. Of the medicines I just told you, these 3 biologic classes that are approved, what's their efficacy? About 60 to 64% efficacy. That's considered good. But is it really?